I can talk loud. It wasn't on. All right, there we go. With Craig's leadership in the division, the entire division of hematology, from the basic science effort all the way to the clinical effort, really has revolved around the study of leukemia stem cells. And this has been a really, really exciting opportunity for me to sort of dovetail the clinical interests with the strengths of the laboratory effort of the division. Excuse me. And I think over the last couple of years, we've really had opportunity to create this great synergistic program that's really dynamic and exciting. And so, you know, we've done a lot of thinking about leukemia stem cells and the clinical applications of them in clinical practice and preclinical work and translational efforts. And it's some of those that I want to share with you today. So just by way of a little bit of background, I spend my days dealing with AML, acute myeloid leukemia, and it's a disease with a really awful track record. It is the most common acute leukemia diagnosed in adults in the United States. With that being said, it's a relatively rare disease compared to other much more common malignancies and other diseases. But being that it is among the most aggressive malignancies known to man, it's really out of proportion in terms of the rate of mortality of patients who are afflicted with AML. And in fact, you know, with few exceptions of some subgroups, most patients with AML can expect to die from their disease. Older patients who really constitute the majority of this disease, this is a disease of the elderly, do particularly poorly. And this is because of both biological features to their disease that makes them more resistant to chemotherapy and have worse outcomes because of that. But they're also more resistant to and more susceptible to death from the otherwise intensive regimens that we usually apply to patients who are younger patients with this disease. So for a variety of reasons, they have a particularly bad time. So, you know, we really think in response to this that the key feature of this disease to know and understand is the leukemia stem cell population. And then, you know, to take that one step further and target that in the clinical setting. So what are these leukemia stem cells? This is that small subpopulation of leukemia that allows for both the maintenance and propagation of the disease. It has both self-renewal and proliferative capacity. We functionally define this population as that population of cells that is able to engraft an immunodeficient mouse model. We'll talk a little bit more about that later. And when relapse occurs, which as I suggested to you is almost always in patients with this disease, it is the source of the relapse. So moving on to a potential therapeutic target, BCL2, and its implications for blood cancers in general, and then in AML more specifically. We've known for a while that BCL2 is an appealing target in the lymphoid malignancy CLL. And, you know, really besides both CLL and AML having leukemia in their names, there's very little similarity between these two diseases. One is of the lymphoid compartment, the other the myeloid. They don't really share oncogenic driver mutations, cytogenetic abnormalities. They're very, very different diseases. But in CLL, BCL2, which is an anti-apoptotic protein in the apoptosis cascade, is overexpressed in nearly all cases of CLL. And this allows for inappropriate survival and chemoresistance of this disease. And so you can imagine it's a very attractive target in CLL. And in fact, there's now, in the last several years, there have been lots of efforts to target this. Venetoclax is a very specific BCL2 inhibitor, and it was given FDA approval for CLL just this past year. Preliminarily, we have reports, and I'm going to take you through these, that BCL2 is an appealing target in AML as well. But when you think about it, I mean, AML, like I said, is a completely different disease. AML does not have universal BCL2 overexpression. But that has not stopped most of our colleagues, as well as the company that produces this BCL2 inhibitor, from simply assuming that the mechanism is the same, that the activity in AML should be the result of an impairment of the apoptotic pathway. And we think otherwise. And the reason for that comes out of Craig's lab work and a paper published several years ago now, showing that the ROS low population is a specific subpopulation of AML that functionally is defined as an LSC containing population because of its ability to engraft this mouse model, this immunodeficient mouse model. And so when you drill down on the ROS low population, you find that BCL2 is highly overexpressed in that subpopulation. Again, that defines a population of leukemia stem cells. Taking it one step further, when he and his group targeted this with a precursor to the current BCL2 inhibitor that we have, a less specific BCL2 inhibitor, it was very specific to target the leukemia stem cell population. So for all these reasons, we felt that BCL2 would be an active target in AML because it represents a leukemia stem cell marker. So because of this and other observations, a single agent early phase clinical trial was done in relapsed and refractory AML patients. And I've given you sort of a summary slide of the efficacy of the outcome of this trial. And it was not overwhelming. So, a response rate of about 20%, which when you look through the literature for decades of failed therapies in the relapsed refractory AML setting, the hit rate is usually about 20%. Almost anything that has been trialed and published gets about a response rate of about 20%. So this is right there at that sort of usual line of expectation in the relapsed refractory setting. So not terribly exciting, but fortunately this was taken one step further to a follow-up clinical trial. Now this time the venetoclax, the BCL2 inhibitor, was paired with a backbone therapy, a hypomethylator, either azacitidine or decitabine. These are sort of felt to be the de facto standard of care therapies for elderly AML patients who can't tolerate standard intensive induction chemotherapy. And the population in this study was different. Instead of relapsed and refractory AML patients, now we have upfront, previously untreated AML patients that got this regimen. And the results are quite different and I think really exciting. In fact, this is unlike anything that we've really ever seen to date in this population of patients. So response rates now, if you include complete remissions, what we call incomplete complete remissions, or complete remissions where there's incomplete recovery of peripheral blood counts, or partial responses are you can sort of disregard, but this is also a real finding, what we call morphologic leukemia-free states, where we look at the bone marrow and we don't see any increase in blasts, despite not having recovery of cell counts, hemoglobin, platelets, neutrophils. So when you sum all of these up and the very significant just pure complete remission rate, we're looking at a near 80% response rate. And so, again, with the de facto standard of care of a hypomethylator alone in this subpopulation, we would expect about a 20% response rate, maybe 30% response rate. So this was really, really striking and exciting. So the question that comes to mind then is obviously, well, what accounts for this difference is, between the first study and the second study I showed you? Is it because of the backbone therapy? Is it because in this setting we're pairing a hypomethylator with this investigational agent that targets BCL2? Some people might believe that or think that, but I would offer to you that there are now 3 different backbones that have been tried with this investigational therapy and all have pretty much the same readout, between a 70 and 80% response rate. So to invoke synergy with 3 different backbone drugs is a bit of a stretch, I think. We think that it's more reasonable that the difference here is really because of the setting. The fact that now, instead of having relapsed and refractory patients, we're treating previously untreated patients with what we believe is a stem cell-directed therapy. And why should that matter? Well, this is the reason. And this is, again, a collaborative effort from Craig's lab and some colleagues in Rochester. But they looked at some features of leukemia stem cells, first in the upfront AML setting. This is before treatment. And I'll just take you through here. This is one of those functionally defined, engraftment studies with the immunodeficient mouse model. And you can see that in the populations that we would expect leukemia stem cells to reside, particularly the CD34 positive populations, that's where you get engraftment. In populations that were not CD34 positive, you do not get engraftment. And again, this is in the upfront diagnostic sample. In this, when you take paired samples, give them intensive chemotherapy, give patients intensive chemotherapy, and they relapse, and then you basically do the same experiment, you see something really, really disheartening. And that's that leukemia stem cells now reside in compartments that you would not expect them to be in, CD34 negative compartments. And I'm not showing you here, but what was reported is that the frequency of leukemia stem cells was much greater in the relapse setting. So in essence, if you treat a patient with acute leukemia with intensive chemotherapy and you don't cure them, you just made their disease unbelievably heterogeneous with respect to the leukemia stem cell population. And it's really difficult to conceive of bringing in a leukemia stem cell directed therapy in this very splintered, heterogeneous population and making any real impact. But you can imagine that if you deliver that leukemia stem cell directed population here in the upfront setting, you can make an impact. And that, I think, is what we're seeing with the early results of these venetoclax studies is, deep, significant, durable responses in the upfront setting and more cosmetic and less frequent responses when you deliver that stem cell directed therapy here. So this all sort of forms our approach, our sort of approach to acute leukemia at our institution. And really, I'll explain to you why I think this, but in a lot of ways, this is like a flight crash investigation when you have a patient with AML. And that's kind of how we think of it. It's an impending disaster, but one that we can get more information on and potentially intervene in to prevent that disaster. So, when we have a patient with AML newly diagnosed, they have a high tumor burden. We do something like intensive chemotherapy, if it's tolerable, to debulk them. And if we're lucky, we get it down below this detectable level where we say they have experienced a complete remission. And that just means we don't see any blasts or leukemia cells on a bone marrow biopsy. But with time, as I told you, almost everybody will ultimately relapse. And at that point, it's difficult, if not impossible, to manage. So we know a lot about leukemia stem cells now from the upfront setting based on work that Craig and others have been doing for decades. And now with this paper that we published, we even know a ton about leukemia stem cells at relapse. And as I showed you, it's very powerful to be able to pair these time points within the same patient and know a lot about what's happening. But that doesn't really help us. That doesn't help our patients in real time. What we need to do to help our patients in real time is know what's in this literal black box. What is happening here during this time point, and how can we understand what's happening here and potentially intervene? And that's the flight crash investigation that needs to happen. And I call this recovering the black box. But how can we do that? How can we get this information? It comes down to frequent and sequential sampling of these patients during treatment. So when they're in remission, and knowing and understanding what's happening sort of a little bit behind the curtain. And then looking at this with a resolution that allows for the discovery of subtle but actionable changes. And it's our philosophy that, if a plane has a high likelihood of crashing, we should start to do the investigation before the crash occurs and then maybe prevent it. So I think getting this information during these time points is really crucial. And that's the focus of this program we've established with the division and the Hematology Clinical Trials Unit that we call Dynamic Personalized Medicine. So frequent patient sampling, whether by bone marrow biopsies or peripheral blood, and then outputting that into a high-resolution immunophenotyping model. We use CyTOF, or mass cytometry, and then also in parallel doing single-cell genomic analysis. And both of these things in concert really allow for us to detect changes in responses to therapy and disease progression before they're clinically detected, and give us actionable readouts that can hopefully bend the curve and prevent a relapse. Because as I showed you, particularly with respect to targeting leukemia stem cells, once the relapse has happened, we're not very optimistic that we can do much about that. So let me give you some examples of our approach and where we're going and why we're so hopeful about this. So these are two examples of patients that have received novel therapies in the setting of clinical trials. This patient, a 73-year-old with newly diagnosed AML, got venetoclax, the BCL2 inhibitor, plus azacitidine, so one of those study patients that I showed you. And then this is a patient who also had AML, who had a prior therapy, and then received a therapy called AG221. This is a targeted therapy against IDH2 mutations, which about 20% of our patients have. It's a very exciting direction that we have in the clinical trial setting of a targeted therapy for patients who have that mutation. So on the surface, I'm just showing you kind of clinical lab parameters. Both of these patients experienced remissions. With by definition, the blast sort of decreased to below detectable levels. And clinically, you know, if you looked at a bone marrow biopsy report for both of these patients, you would say that both of them had equivalent remissions. But using the dynamic patient monitoring program, and particularly here CyTOF, we can pull that curtain back. And we can know and understand a whole lot about what's happening under the surface at very early time points sequentially. So these are, you know, very close together dates that we're doing this peripheral blood sampling and analyzing with this multi-parameter analysis. And you can set the resolution anywhere you want. So Brett, who's in the audience today, who does most of this work, set the resolution here for these two different patients at these time points at the top 25 different subpopulations as defined by particular immunophenotypes. And so you can see there's a lot going on that we can know and understand through all of this analysis. There are some clones that are escaping and setting the stage for resistance, and then there are others that are quite sensitive to the therapy. So you can probably get at least a gist of how valuable this information is when applied to a clinical trial setting. So an investigational therapy that we don't even quite know the mechanism or understand mechanisms of response or resistance, having this information is really, really powerful in a clinical trial setting to be able to understand this. I'm not going to get into this too much, but in a similar fashion, we can use genomic testing. So this patient here had 3 particular mutations. This is just a SNP, the TET2, but you can see with response, in remission, the SRSF2 and these are just the blasts significantly went down. At the time of relapse, you can see as defined by the blast going up, the SRSF2 clone is on the move, and then the CBP alpha that was barely present at diagnosis is also on the move. And so, you know, these are the types of things that can really powerfully inform us as to how or why drugs are working, novel mechanisms that we hadn't yet thought of, very rich hypothesis generating type of information. So drilling down a little bit more on the first patient who got venetoclax that I told you about, this patient, again, he had newly diagnosed AML. He got the venetoclax plus the hypomethylator. He had a very nice remission. And then for a variety of reasons, he opted to come off the study. And unfortunately, after several months after that, he relapsed. But this gives you a sense of the power of this approach, the dynamic patient monitoring. So here what Brett did was he called out the 4 or 5 most sensitive populations to the therapy and the 4 or 5 most resistant subpopulations to the therapy. And so you can see very nicely, and again, this is all defined by particular cell surface markers. But then you can see at around February 23rd, this is sort of an inflection point where the most sensitive subpopulations are sort of plateauing, but there seems to be an acceleration from these more resistant populations. So if we drill down on this time point, and use intracellular markers, this really gives us what could be the answer for the mechanism of resistance to this novel therapy. So these are the 4 or 5 most active increasing population as defined by particular intracellular signaling pathways. So you can see P38, NF-kappa B, MCL1, these are probably what is driving resistance to this novel therapy. So in time, what we hope is that we can do this measurement prospectively. And at the time of a patient who is in remission and everything looks fine, we can get a glimpse of this type of activity under the surface and intervene. Because there are therapies that are active against NF-kappa B signaling pathways. There are therapies that are active against P38. And these early interventions, we think, could potentially head off relapses in our patients. So just to sort of sum that up, we think this DPM project has very exciting implications. We are getting a glimpse at real-time evaluations of responses to either conventional or, in my opinion, more excitingly, these experimental therapies. And that's allowing for these detailed assessments of relapse and the potential to predict that early to occur based on what's happening with all these different subclones, depending on how we define what the subclones are. And then we can intervene, and that's really the hope and expectation is that be the next step. So backing up a little bit from the DPM project, just this whole new field of targeting leukemia stem cells in the clinic is really, really exciting. And this is a new development. So like I said before, people like Craig and others for a long time have been working on exactly what are the salient features of leukemia stem cells. Based on their work, we now know so much about that, but it's only in the recent couple years that we've had the weapons in our arsenal to be able to therapeutically exploit those weaknesses that Craig and others have been telling us leukemia stem cells employ, and really be able to effectively target leukemia stem cells in the clinic, which is, I think, if there's any exciting direction that's going to be in AML or myeloid malignancies, it's going to be through targeting these leukemia stem cells. And so, when we're thinking about doing this is a completely new era. New rules are necessary, and we've been working a lot on on what these rules should be when writing clinical trials, when assessing endpoints for clinical trials with drugs that are purported to target leukemia stem cells. So I summarized some of these here. We really need to quantify the actual impact on leukemia stem cells in the context of your clinical trial. So no more guesswork that this drug worked, we think it was leukemia stem cell directing therapy, therefore this drug targets leukemia stem cells. Instead, in a clinical trial setting, we need to be able to prove that a purported leukemia stem cell directed agent actually does do what we're saying it's doing. And then also thinking about how to sequence this with debulking therapies. So as I told you before, leukemia stem cells are a tiny subpopulation of the disease. They're the root cause, but at the time of diagnosis, you have this unbelievably proliferative blast component that doesn't necessarily share the same features of leukemia stem cells. So you have to be able to pair a stem cell directed therapy with a debulking agent. And the ways to do that are myriad, but these are the things that we're working out and trying to really take a leadership role in. Venetoclax really appears to do what we would predict a leukemia stem cell directing therapy would do. That's not an opinion that's shared by necessarily our colleagues or the company, but it's something that we really believe in and are working to prove. And we think that based on the high rates of responses, the deep responses, and the durable responses that we're seeing with this therapy, all of those line up with the preclinical prediction that's how that's how venetoclax works in AML, despite how it may work in CLL. And so, what we're working hard on now are these correlative xenograft studies using the patient samples to actually prove what I summarized before, that venetoclax, and in the case of the other study I told you, IDH, that whether or not these drugs are truly targeting leukemia stem cells. And we have the ability to do this, and we're very excited to be able to start to do that now. And there's a range of other questions that are being generated and that are yet to be generated that we can work on that are really exciting. So, I think that the real potential here, the DPM program, is to, in real time, monitor responses, not wait for a relapse, not be satisfied that a pathologist looks under a microscope and doesn't see any blasts. We can really understand the mechanisms that may be brewing that would ultimately result in a response and head those off. And I think instead of trying to come up with leukemia stem cell directed therapies that could work in the relapse setting, because as I showed you based on that paper from Blood this past year, that's a really, really difficult challenge. How about we just prevent relapse from happening at all? I think that's the direction I would be much more in favor of going forward. So with that, I want to thank you for your attention. This is work that is a joint effort, both of the Hematology Clinical Trials Unit, which is a brand new venture of the Hematology Division that we're really, really excited about, and as well as collaboration with, of course, the Jordan Lab. We've had great success with funding sources, and I particularly want to thank the Department of Medicine's Early Career Scholars Program, which has been really generous with me and allowed this work to happen. So thank you so much, and I would love to take questions if there's time. Dan. Essentially what that first study was, in fact, as a single agent in the relapse refractory setting, I don't think pairing it with azacitidine is going to be encouraged by change, maybe develop something or find something that get that under control, which I think with venetoclax and other related therapies, population of the hopefully shrink to very now it's kind of there's a lot of talk about this, whether I'm not a big, I don't really buy that argument. The regimen belief is